So I'm back. Last topic I had to rush because of obvious reasons. Anyways, now I'll be talking about something regarding molecular diagnostics. A lot has been done in past few decades about molecular diagnostic. We have a lot of biofires, PCRs, not even that serological markers. They have come up in a big way, and we encounter them in our day-to-day life. We keep thinking about where to apply them, where not to apply them. So with this next 20-minute talk, I'll try to we will try to figure out where we can use it. So, yeah. So we'll see science behind molecular diagnostic. When we say PCR, what do we mean? It's working, right? Okay. What do we mean? When to use these tests, and which one and how to interpret, and whether or not they are helpful in stewardship programs. So, see, we know that most of these molecular diagnostics which are available have been initially targeted for viral infections alone. Now we have molecular diagnostics available for your bacterial organisms, for fungal PCRs I was talking about in my previous session. So they are coming in a big way. So we have to just figure out how to interpret them in the right way. But having said that, acute respiratory viral infection remains a big problem and cause around 5.8 million deaths worldwide. Clinical signs and symptoms of any acute respiratory infections are not very specific. All the acute infections may not present with a similar kind of symptoms, and their presentation is always confusing for a clinician. So these molecular diagnostics can identify the bacterial infection, they can identify the viral pathogens, and to some extent even now we have availability of fungal pathogens as well. So if they are available, you get quick time of, the time to diagnose the disease cuts down. So any culture, fungal culture, as we all know, actually takes 6 weeks, sometimes longer than that, and we don't even know how long, whether they will grow or not, because the sensitivity and specificity of those cultures are very poor. So, So when we see PCR is actually basically 3-step process. It has a denaturation, so you will take a small component of a genetic material, they will denature it for around 3 to 5 minutes, then they will anneal it, they'll cool it down so that the primers are ready, and once the primers are ready, they will run a cycle to extend these PCRs, and full genetic sequence will be formed, which is picked up by the machinery. So then the PCR is the 3-step mechanism. You can see in this step 1, and then denaturation, then annealing, then elongation, and once the elongated PCR is available, you can actually figure that out by putting them in a primer. So the above steps which I told are repeated in multiple cycles, and the sequence of interest is generated. Once that is generated, you can up to 1,000 DNA base pairs, then you can actually figure that out which particular virus or bacteria these things belong to. And it takes very less time, it takes a minute's time. Once you have annealed and done everything which I stated earlier, it takes only a minute's time for you to figure out the DNA sequencing. And this whole process can actually be done within 3 to 4 hours. It depends from lab to lab how much time they're taking, but as far as the process is concerned, it is not longer than 3 to 4 hours. So if your lab is proactive, has good amount of manpower, you send a PCR in the morning 9 o'clock and you will have the answer by 1 o'clock. If at all you have a lab which is not very rushed into and you have a person whose manpower is not a constraint. So once PCR is completed, we do gel electrophoresis and the DNA fragments are detected. So nucleic acid amplification test, which is nothing but PCR test, is actually a gold standard for viral pathogens and is beneficial in several ways which I stated. It reduces the unnecessary antibiotic usage, so it also helps in antimicrobial stewardship. Improves the antiviral prescriptions, so you will not overprescribe or underprescribe the medications. Limit the additional ancillary testing. Suppose I sent a viral PCR just for flu. In the beginning of this thing itself, the patient presented with ARDS-like picture, which recently you saw a lot of ARDSs, and you get a lung pathology, you do a PCR, and you get a flu positive. Influenza A comes back positive. So you can actually, at that point, you know the answer, and you can limit a lot of testing, unnecessary testing if at all required, and you can get to the conclusion very quickly. So it helps in limiting the additional test, and it also may reduce your or shorten the stay in the hospital, stay in ICU, and optimize the infection control practices, of course. So all these guidelines, IDSA, American guidelines, Australian guidelines, and European guidelines, they all, even Indian guidelines for that matter, they all actually promote the use of or endorses the use of molecular testing for at least influenza. And now coming to the question, I'm saying everything is good, this looks rosy. Is it actually as good? So how good are these molecular tests? There's a problem. Everywhere, whenever we start saying too many good things, no, the problems are always there in the behind side. So we should always be careful when we are hearing too many good things about any particular test or medicine. So just be critical at that point and look at the hindsight and look at the problem aspect of that. So what is the problem with this particular thing that I'm saying? There is problem with the data. Heterogeneity and variable quality of testing is a problem. So all the tests which are available in the market and in the system are not equally, so their results cannot be, again, reproduced at different centers. So you have to be carefully interpreting or use a test which is largely validated at different centers as well. Again, most of these studies which have proven the benefit are very small studies. They have very small sample size, and the comparison is usually with the historical controls. So that again is a problem. So whenever they say that there is a test available like this, you have to see how it is working in your setup, use for some time, let your microbiologist validate it, and then try to interpret it after that. So there are several ones available. I will not go into that detail. What I'm trying to say is that probably all diagnostic molecular tests are not equally good. Hence, choose the good ones. CAFED and all those things are very standard, and they can be reproduced or replicated. Their benefits can be replicated at different centers, so inter-center variability is lesser. Hence, you use good, big, validated tests rather than non-validated testings. So a good PCR or molecular test should have a clinical efficacy and diagnostic efficacy. It should help you in diagnostic decision making. It should not confuse you further. And again, it should help you making a decision about the therapeutics of the patient. You should not again stay confused or overtreat or undertreat your patient once that test is done. And again, it should help you in making the patient better faster. So outcome efficacy should also be there. So these are all conceptual hierarchical things. So this is what we expect from a PCR. Is the PCR which has all these quality available? Answer is actually no. So now again, PCRs were taking longer time. They were still taking 3 to 4 hours, and we wanted to do it faster, like 3 minutes, 4 minutes, bedside. So that is what a point of care test is. And it is something that provides very rapid turnaround time, has reduced the pre-analytical errors because it is usually bedside, done in your center. There's no transport of the material that's happening. And it gives very quick, fast, appropriate results, and hence improve the clinical and economical outcomes of the patient. So, but it should, all these POCTs are your BioFires. So these should be, whenever they are designing a POCT, they should be easy to use. The things that are required to do should be very simple. So it should not be a complicated test because you are going to be using it quickly and you want your answer quickly. So anything cumbersome to use or difficult to use will become a challenge. Hence it should be easy to use, it should be easy, consumables should be easy. And POCT should align with the established lab methods. So it should not be something out of the box just because you felt that it can pick up something, you have it introduced into the system. That should not be the case. And it should be safe. So you cannot have a biohazardous thing happening inside your hospital. So So they tried to look into, this is a multi-center study which tried to look into what happens to the, when you use diagnostic molecular testing in adults with respiratory illnesses. So they said that for influenza and RSV, this actually reduced the length of stay significantly if at all patient underwent these testing in the initial stage itself, and also other microbiological test utility was also lesser. And in such patients, they said that economic and length of stay can something that definitely have a good impact if at all we use these tests in a patient. This is another study which, from the similar one, they said that there was definite reduction in the utility of the other testings, and we were not testing differently. So this is a representative example of how we have moved on from ELISA to conventional LFAs to something now they are looking at time-saving LFAs. So this is how they are subsequently moving to reduce the turnaround time of each test, and from we have moved on to somewhere around 1 day to 4 hours to now 30 minutes also we can get an answer. So this is one case, a 24-year-old female who is not immunocompromised, no premorbid conditions, is fully immunized, presents to a physician's OPD with cough, runny nose, fever for 3 days duration. The patient's other colleagues had similar symptoms. The patient is febrile with other vital signs being normal, no signs of respiratory distress, and her lungs were clear, examination was absolutely normal. So there was no respiratory test that was prescribed to this patient. She was assured and said that eat paracetamol and go back home. Forget the year, just let it be 2024. Maybe, don't get confused with COVID. I have nothing to do with COVID in this case. So 2024, suppose this is happening today. So what do you think? Will you do the same thing in your OPD? No? Yes? No? Yes? How many will do same thing in OPD? Yeah, okay, I see few hands. How many will do something differently, and if yes, what? Okay, okay. So maybe we'll see. So see, for case 1, probably what they did was not wrong, because most of the viral infections, see, she had something similar going on among her colleagues. She's an immunocompetent individual. She has been fully vaccinated, so we are presuming that her flu shots are done, her COVID shots are done, everything is done. And whenever you are trying to do a test, suppose she presented in a month where the prevalence of flu, which we see in that part of the country, is lesser. If at all, the low prevalence time you are trying to do a test, then the chances of false positive will be higher. So this is something we should always remember. Dr. Vishnu was briefly mentioning that when the positive predictive value is not known, when you don't know what will be the test showing you, and if the prevalence at that point in time in the system, in that particular season is lesser, try to avoid that test, because you may get a lot of false positives. That is one reason. But apart from that, other reasons are that most of the virals in OPD get resolved on their own. They don't need an antibiotic. 3 days of fever, patient is better, respiratory system is fine. If you don't do anything, even as per guidelines, you won't be wrong. Okay, so there is a chances of, see, my mouth can have or my throat can have flu, mycoplasma, adeno, and maybe COVID, you don't know. A lot of viruses sitting there. You do a swab, you find one zoo, and what do you do after that? You see, means how many things you want to treat. You would want to treat me for COVID also, maybe you'll throw in an AZ also, then you'll give me oseltamivir as well. A lot of things will come up, and hence, I'll be bombarded with medicine for a virus probably which has not been picked up in your PCR. So maybe it is a virus totally different, entirely different. So in OPD practice at least, we can be gentle to the patients, give more of paracetamol and water rather than anything else. Hence, not doing a test when the prevalence is not very significant is a prudent thought, and in a non-immunocompromised individual who has been immunized completely, is otherwise stable with no signs of shock or respiratory failure, you can get away without giving anything or doing a test. And it is true for pediatric population. This is from a pediatric journal, and their guidelines say that clinicians should diagnose bronchiolitis and assess severity on the basis of history and physical examination. If they only feel that the patient has signs and symptoms of worsening disease, then the testing should be done. Now this, again, you get flu virus, you have some treatment, oseltamivir. In an immunocompromised, you get adeno, you have some treatment, or RSV, you have some treatment. What about all other viruses? There are para-influenza, para-pneumo, so many metaviruses, so many viruses are there. Do you really want to keep testing for them? If you look at the panel, there are like 7 other viruses. So in a patient who is not immunocompromised, if you really have a normal patient who is otherwise doing fine, you can get away without testing them. That's first thing I want you to know. And there is no data about non-influenza viruses. So the data about them is so sparse because probably we have not tested it as much, and we don't know what to do even if we get them. Hence, that gray zone stays because we are very confused about what to be done about those viruses. Most of them are self-limiting. They get better on their own. You don't know, you don't have to do something out of the box to treat these patients. Having said that, once these molecular diagnostics are available, people are trying to generate more and more data. We will know how many people presented with one particular virus is one setup, and we will probably know how many of them can get sicker, which may behave differently, and whether there is a treatment or not for those. So yes, there are benefits of doing these tests as well, but by and large, it is okay to do them in an immunocompromised individual alone. So what happened when we do POCTs in such patients? So whether they stop and a clinician probably using an antibiotic or not is what they tried to look into. And they found that although it did not reduce the proportion, the POCT usage did not reduce the proportion of antibiotic usage, but it definitely reduced the length of utility. So that helps in antimicrobial stewardship. Now I was talking about viruses. In next few slides, very few, so don't get bored. Very few slides I'll be talking about bacterial pathogens. Bacterial pathogen, I'll start with the case. So 51-year-old male with post-lung transplant, admitted in ICU 2021, presented with respiratory distress and new bilateral infiltrates. So known diabetic, 11.7 HbA1c, started on empirical vancomycin, peptaz, oseltamivir. And since he was worsening, next day a pulmonary team decides to do a bronchoscopy. So now gram stain bowel fluid shows more than 2 plus GPCs and multiple polymorphonuclear cells. And they ran a multiplex PCR, which is available at most of the centers, targeting viruses, bacterial defects. And then it detects MEK positivity, Staphylococcus aureus with 222 genome per copies, and H. influenzae. Bowel cultures remain negative, which can happen a lot of time. Why does that happen? Most of these patients are antibiotics exposed, so you having a chance of picking up a culture positive organism in such cases is very less. Therefore, relying on genetic mechanism is more. So this study shows, now we'll come to that case later, we'll park it there. So this study shows that whenever there is a worsening of X-ray infiltrates, that is an independent predictor of antibiotic uses. So if you see that the patient's lungs are worsening in any way, at least on an X-ray, or now there is a bedside ultrasound that our intensivists very nicely use it. So if you see infiltrates worsening, that should be your first indicator for change or up your antibiotics. But this rapid testing does not appear to be helping in stewardship intervention in any way. So this patient was continued on all the antibiotic, and his antibiotics were escalated to meropenem further. So in such cases, what do we do? So in general population, most of the cases we should use multiplex PCR for influenza testing. In pediatric population, there may be some role of upfront PCRs. RSV and adeno-PCR in HSCT patient will help you in diagnosing. And multiplex viral NAT is important in immunocompromised, critically ill, and airway disease. But these bacterial PCRs and other things have a problem. High analytical and sensitivity, less chances of missing important pathogens. So the benefits are you will get answer quickly. It will have a high negative predictive value. So if it is not detected, it is not there mostly. Hence, de-escalation of antibiotic for that perspective. At least you don't find influenza, you can remove oseltamivir. That can be done. Stewardship practices will be better. Quantification of 2 minutes. Quantification of colonies can be done. So you see in the previous sample that I showed, example question number 2, our second patient actually had more amount of gram-positive cocci that you could assess, and the colony counts for your Staphylococcus aureus were more. You did not see any GNB, and your H influenza copies were lesser. Therefore, probably that infection is community-acquired Staphylococcal aureus infection. You don't know the sensitivity, but MEK gene can actually help you with the detection of whether MRSA is there or not. Sorry. The problem with this is that it can detect multiple things. As I told, you can have a zoo for you and you will not know what to do. Therefore, you have to reassess your patient, look at the gram stains, look at other things as well alongside. Prolonged viral shedding can happen, so a lot of time when the patient is recovered from the virus and actually suffering from a secondary bacterial hit, you'll be picking up the virus which you had earlier and you may not be right at that point. It can detect dead, fastidious, colonizing, metabolically impaired organisms and which may confuse you further. And differences among the individual panels and target across the manufacturers is huge. So there is a wide difference between what they detect, what they don't. So whether you are covering by taking one PCR, you're covering everything, we don't know. And so this says that our samplings, our gold standards still stay gold standard. These can be aids. This is to show that pulmonary sample, by teaching, it says that the lower respiratory samples are the best samples. But this particular study I wanted to quote because this actually said that pulmonary samples for Legionella pneumophile is only something that is superior. Other samples, the sensitivity is actually similar for other viral PCRs at least. So LRT sampling after negative URT sampling is advisable when there is strong clinical suspicion of influenza or RSV and is recommended more in immunocompromised individual with lung infiltrates. Across the studies, we said that there was definitely some amount of antimicrobial stewardship benefits with utility of these molecular PCRs, although it has not reduced the prescription of antibiotic, but it has brought down the number of days that antibiotics were being used. But there are some unmet needs. We still don't know whether they are detecting colonizations, and we still stay confused about the zoos that we see. And there are targets which are very important and still not covered, like non-tubercular mycobacteria, nocardias, fungi. Prospective studies of antimicrobial stewardship intervention needs to be done, so we need to look into that part of it. So now, coming to summary, influenza PCR, we have good data. We can use it whenever required in immunocompromised individuals at least to come down on the medications. For pediatric population, immunocompromised pediatric population, definitely they have a better role in using it upfront. Colonization versus true infection should always be kept in mind because colonization can actually lead to over treatment. Hence, you should look into the CD findings, X-ray findings, host aspects, everything, and then keep everything together and try or treat or not to treat that particular bug that you isolated. Molecular tests are good aid in patient care, but they cannot replace the gold standard still, and it definitely needs the correlation. Individual assessment and better comprehensive care is something, so individualize your treatment. I wanted to say the same thing for the fungal infections, and I would say the same thing for viral and bacterial infections. So individualization is very important. With that, I would end my slides. Thank you.
Thank you, madam, for the